Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Maad, for your kind introduction. Assalamu alaikum. Good morning, everybody. First of all, I would like to thank you for your attendance, and I hope that you are enjoying the conference and meet your expectation. I'm going to talk about the osteosarcopenia, and this is the objective. We're going to talk about the age-related change in the muscle and bone leading to osteosarcopenia, and touching the pathophysiology as well as summarize the management of osteosarcopenia. So as we know that the bone and muscle, it's very close to each other. The peak bone mass reaching the maximum at age of 25 and then continue to be plateau, and around 50 start to decline gradually at a rate of 1% per year. The same concept applies to the muscle, where it reaching the maximum at age 25 and then start to gradually decreasing at a rate of 1% per year. That means we are almost losing half bound of lean muscle mass after the age of 30. That's why they said if you didn't use it, you will lose it. So this is the importance of the maintaining the muscle mass by doing exercise. So if we're gonna to put it together, bone and muscle, there is significant overlapping. Both they are declining with aging. That means there must be something happen to both of them that explaining this declining. So as we know that decreased bone mineral density will lead to osteoporosis. Osteoporosis will gonna increase the probability of the fracture. And the other way, decreased muscle mass and function will lead to sarcopenia. Sarcopenia increase the risk of falls. Most of the hip fracture, it's occur because of falls. And unfortunately, most of the time, the management of osteoporosis is fragmented. We didn't looking after the muscle health after the patient get fracture. Until recently, around 2009, when Dr. Neil Blinky and his colleague proposed the osteosarcopenia. Osteosarcopenia, it is the combination of two common diseases, the osteopenia, osteoporosis, and sarcopenia. Osteoporosis easily diagnosed, and there is agreement by WHO criteria. The story is more complicated for sarcopenia because unfortunately we didn't have any agreement or consensus with regard to the definition of the sarcopenia. We have so many guidelines, and I just summarized the most common three guidelines, the European, American, as well as the Asian, and we're gonna to talk about it later on. Osteosarcopenia gaining more traction since it has been introduced, and this is the PubMed publication. As you could see, it is far away from the vitamin D publication that has been presented by Dr. Amuna Foda. But as you could see, very few paper. Last year, around 70 paper. Why is that? Because it's very common. Osteosarcopenia estimated to be 1/3 of elderly patients having osteosarcopenia. And it's increasing with age. Those who are 75 and above, it's approaching 50% or even higher. And that's why Prof. Gustave Duke, one of the figures in the field of osteosarcopenia, he recently published this paper, and he stated that osteosarcopenia should be considered as a geriatric giant of the 21st century because the high prevalence. And he added that to understand and effectively diagnose and treat osteosarcopenia, we still require a clear clinical definition of sarcopenia. We will stop now at this stage talking about osteosarcopenia, and we want to highlight the sarcopenia. What do we mean by sarcopenia? Sarcopenia, firstly, the first physician who described the muscle aging-related decline was the Rosenberg back in 1988. It's come from the Greek word, two-part, sarc for flesh or muscle, penia for deficiency or decrease. Honestly, I don't know the appropriate translation of sarcopenia in Arabic. To implement the sarcopenia in the clinical practice, we have to have clinical definition or diagnosis. Perhaps this is the first definition for sarcopenia in 1998. It was focused on muscle quantification. However, since that time, multiple definition has been existed by expert group. In 2016, it was landmark time in the history of sarcopenia because this is the time when the ICD-10 recognized the sarcopenia as a disease. So the first consensus for sarcopenia done by the European group of sarcopenia back in 2010. As you could see here, they recommend using presence of both low muscle mass as well as low muscle either strength that measured by the hand grip or performance that could be assessed by gait speed. As you could see here, the entry door for the sarcopenia, those who are 65 and above, to assess the gait speed. A lot of factors that leading to decreasing the gait speed other than sarcopenia. Elderly with severe osteoarthritis, patient with severely obese, patient with cardiac disease or respiratory disease, all of these factors would leading to decrease the gait speed. And after multiple study has been done in that field, the same group, they met again in 2018 and they revised the definition with this very nice algorithm. As you could see here, the entry door, more objective tool using the SARC-F. And we're going to talk about the SARC-F later on. So if the patient having positive SARC-F or clinical suspicion, they are a candidate to be assessed for sarcopenia. And how could we assess? By measuring the muscle strength either by the hand grip or the chair stand test. If it's positive, the sarcopenia probable. And at this stage, it's in the clinical practice. This is enough to trigger further assessment. So how could we confirm the sarcopenia? We have to go to assess the muscle mass quantity or quality by DEXA or bioelectrical impedance or by more advanced imaging like CT or an MRI. If it's positive, the sarcopenia already confirmed. But if the patient having physical performance affected as well, so the patient candidate for the severe sarcopenia. Moving from the European to, this is the SARC-F. It is very simple tools that is 5 questionnaire. Rapidly identify people at high risk for sarcopenia, and I think this should be implemented in the clinical practice. If the patient having 4 or more points, they are a candidate for more sophisticated test. Moving from the European to American, the American, on the other hand, they use the hand grip to assess the muscle weakness as well as the gait speed. But on the other hand, they advise not to use the DEXA. We shouldn't use the DEXA. And this is their position, a statement that published 2020. The Asian group, actually this is published in 2019. This is an update about the version was in 2014. It's more or less similar to the European. But the beauty here, they have two guidelines. One guideline to apply for the primary healthcare physician because they thought most of the sarcopenia patient could be diagnosed and managed in the primary care setting, again by more subjective, objective tools like SARC-F. If the patient positive, they are a candidate for more sophisticated tests. Well, this is summarized the three consensus or guideline. As you could see, there is different in cutoff point and different in the diagnostic tool. So the implication of that, we have different prevalence. As you could see here, it's ranging from 10% up to 40%. So the lack of consensus definition of sarcopenia has limited the ability of the clinician to diagnose and treat of sarcopenia. So this is muscle and bone, it's very close to each other. This is anatomical cutoff point from the cross-sectional, from the mid of thigh. As you could see, the relation between the muscle and bone. On the left side of the screen, you could see the femur bone in the center, very good quality of the bone, and surrounded by muscle, a good bulk. And on the other side, this is osteosarcopenia patient. The bone get deteriorated, decrease in the bone density, the muscle mass decreasing, and it gets infiltrated with fat. The green triangle, this is the factor that contributing to maintaining the anabolic factor to maintaining the healthy muscle and bone. And the red triangle, the factor that contribute to the osteosarcopenia. So if we want to talk about the pathogenesis of osteosarcopenia, it is virtually the same like osteoporosis. It's summarized to common mechanism, that's meaning affecting bone and muscle, or defecting muscle leading to defect on the bone, or the vice versa. So in the presence of this risk factor, it will be accelerated of bone and muscle loss, like physical inactivity, aging, low protein intake, low vitamin and calcium intake, chronic inflammation, whatever the cause of the chronic inflammation, rheumatological or other rheumatological, fat infiltration, corticosteroid medication, hormonal imbalance like hypogonadal, low testosterone in male or low estrogen in female, and comorbidities like diabetes. All of these factors will gonna to accelerate muscle and bone loss. So fat infiltration of muscle and bone is triggered with similar risk factors. So in presence of aging, sedentary lifestyle, diabetes, excess saturated fat, that will lead to increase the free fatty acid. The free fatty acid will gonna to infiltrate and precipitating inside the muscle and inside the muscle fiber as well, leading to decrease the type 2 fiber, which is responsible to maintaining the muscle function and decreasing the satellite cell, which is important to regenerate the damaged cell. On the other side, free fatty acid will be infiltrate to the bone marrow as well as to osteocyte lacunae, leading to decreasing the osteoplastogenesis and increase the osteoclast. So the end result will have fragile bone. Muscle and bone is very close to each other anatomically, and there is crosstalk between the muscle and bone. Mechanical communication, as we know that muscle contraction, it's very important for the bone health. That's why patients with prolonged immobilization will leading to osteoporosis. But recent advance, they found that there is some factors that's secreting from the muscle called myokines that having biological effect on the bone. And then at the same time, there is some factor that's secreting from the bone to the muscle. So this is called osteokines. So the factor that contributing to regulate this factor is mentioned here. One of the most important, it is the exercise. The exercise will improve the cytokines. That's important for the muscle mass, improving bone density, as well as increase insulin sensitivity and decrease adiposity. On the other hand, aging and physical inactivity, it will leading to increase the bad cytokines that having negative impact on bone and muscle. What about genetic? As we heard from Prof. Sadat yesterday, the genome, it is the future. We know that the big bone muscle and the big muscle mass, it is genetically determined. Here, this is summarized. A recent publication summarized the gene that having share bone and muscle phenotype. We know that virtually all the falls, it's caused by, all the hip fracture, it's caused by falls. And most of this hip fracture, it's due to osteoporosis. But unfortunately, most of the time, we missing the management of falls and muscle health in the clinical practice. So how could we overcome with that? This is the update regarding integrated the sarcopenia and fall into FRAX, as we hear from Miklowski. So we will have, in addition to the 12 items that usually presented in the FRAX, we have additional items like falls, sarcopenia, diabetes, comorbidity. So in addition to the box for the probability of the fracture, we're going to get another box for the probability of falls. So the FRAX update is coming. It will be called the FRAX Plus. I will not gonna throw it because Miklowski have covered this very nicely yesterday. So it's unclear when the FRAX Plus will be available. So what we do clinically now? Well, osteosarcopenia, unfortunately, it is missing in the clinical practice. It is under-recognized, under-managed. And to increase the awareness of that, this is very important paper that has been recently published. Highlight the important sign, symptom, and red flags that should be trigger the physician to do more sophisticated and consider the muscle health as well. So in terms of pharmacological therapy, there is too much work done on growth hormone and testosterone. Both are effective in increasing bone density and muscle mass, but they are not effective in increasing muscle function, meaning helping elderly patients to walk better or decrease the falls. And that's why it is not translated to the clinical practice. In addition to that, there is a lot of concern regarding the safety of testosterone therapy with regard to the cardiovascular and the prostate cancer. What about the denosumab? Denosumab, as Dr. Mohammed Shakir highlighted yesterday, the mechanism of action, it's block the rank L to bind to the rank receptor. The rank receptor, it's existing in the muscle as well, in addition to the bone. So this is systematic review and meta-analysis recently published. The conclusion is denosumab was better than bisphosphonate and placebo in improving the muscle strength. And therefore, denosumab may be favored in individuals with osteosarcopenia to improve muscular performance and reduce the fall risk. So, with regard to non-pharmacological intervention in osteosarcopenia, this is a systematic review. Unfortunately, we didn't have any randomized controlled trial has been examined the effect of the protein, vitamin D, calcium against control or placebo in those patients with osteosarcopenia. So all of these, it's prevent, not an intervention. So how could we emphasize? Number one, fall reduction is very important, and most of the time, the exercise and balance training. Well, this is the recent international clinical practice guideline that has been released. As could you see, they are strongly recommend exercise for elderly patients. And actually, the exercise not only limited to the bone and muscle health, it's beyond that. It is important for biopsychosocial, it's important for cardiovascular, it's important for psychological, it's important for other factors. And the recent review concluding that resistant exercise could prevent development of osteosarcopenia. So this is a meta-analysis, around 18 trials, more than 4,000 patients, and it showed that the balance training called Tai Chi, it's decreasing the number of failure and rate of falls. So that's why the Osteoporosis Society of Hong Kong guideline recently advised that Tai Chi strongly recommended as an appropriate and safe exercise for elder adults for general health and fall prevention. What about the nutrition? Inadequate protein reduces the muscle synthesis, and around 40% of patients with hip fracture have protein malnourished, as well as 40% of elderly not meeting the current recommended dietary allowance. And for health, older people, the diet should provide at least 1 to 1.2 grams of protein per kg per body weight. It's not clear whether the best to spread it over the meal or take it as large single pulse protein. And again, it is not clear that a specific amino acid like leucine are the best. Well, this is summarized the non-pharmacological recommendation. Again, I want to emphasize to prevent osteosarcopenia because we didn't have any randomized controlled trial regarding the intervention. Vitamin D, we cannot say anything after Dr. Amuna Fouda lecture. It's very important to keep vitamin D in the reference range. Protein intake, this is very important. Elderly patients, they have high intake of the requirement of the protein. Calcium, it's very important to take at least 1 to 1,200 milligrams per day. We did a recent assessment of the calcium intake across the kingdom, and just imagine, this is the average calcium intake on those. This is non-published data, around 450 milligrams per day. That means most of our population, they still either to increase the calcium intake from diet or to take calcium supplement. So, in conclusion, the concept of osteosarcopenia has been evolving over time, and I hope that I convincing you, and you agree with you, that osteosarcopenia, the sarcopenia should be integrated in the osteoporosis management, and sarcopenia should be parallel, head-to-head to osteoporosis to prevent the complication that's reaching to increasing mortality and morbidity. By this, I would like to conclude and thank you all.